Good evening. It's Monday night. It's 8 o'clock, and I'm your host every week, Dr. Jacques Doueck. It's Health Watch Radio, and tonight we have a special guest, Dr. Ezra Cohen. He's going to be joining us, and we're going to be discussing some very interesting things about the eyes and eye exams and a lot of interesting stuff. Before we get started with this, I wanted to just mention we're at Erev Pesach coming up in a few days, and Rabbi Moshe Liniato from Ater Torah suggested that I mention this, and that is that you have to be very careful Erev Pesach with a couple of things of safety. One of them is Hagalat Kelim. If you are using boiling hot water, you have to be very careful not to burn yourselves. Try to use heavy-duty gloves. There are a lot of damage that can be done like that. The other thing that he mentioned is Dr. Kimmel, a plastic surgeon, told him that Erev Pesach last year, he had 17 women come with cut hands. When you're cutting things, when you're using a knife, please put whatever you're cutting down on the table. Don't cut into your hand. He says 17 women came to him on Erev Pesach with cut hands because they were cutting the wrong way. So please, let's be careful. Let's follow what the Gemara says and not do things in a foolish way. Again, tonight our guest is Dr. Ezra Cohen. He has 32 years experience as an eye doctor in this community. He practices here on Avenue U, and he's going to share with us some of his insights that he's accumulated over those years. Dr. Cohen, are you with us?
Yes, I'm here.
Okay, great. I'd like to start off by asking you one simple question is, what kind of things do you pick up in routine eye exams for children, adults, and seniors?
Well, it's very varied based on the population of the child. We have individuals that come in with a varied kinds of problems. Children invariably come in sometimes with, believe it or not, bugs in their eyes. From the street, flying through the air, a bug will hit the eye, it'll catch the eyelid and get stuck underneath the lid. We've had adults also as well with the same situation.
So what do? You pick it out?
Yeah, you sit down carefully, you numb the eye, and you carefully tweeze out the bug.
Wow.
It's happened more than one time.
Wow.
Not only in the romaine lettuce do you get it. And metal seems to be a very, very common thing. Other than the iron workers coming in and grinding without their glasses on, again, from the street, large pieces of ferrous oxide have come into people's eyes, and you have to sit and tweeze it out for a good 20, 25 minutes. Very serious. If it sits too long, it's toxic to the eye, and God forbid you could lose your eye.
Wow. Pretty scary. So you're picking that up as an emergency. Usually somebody's coming in with a complaint about that?
Not necessarily. Many times they come in routine and don't even feel it. It's sitting for several days. It starts to absorb in the eye. The patient complains about very mild irritation, and you look in their eye, and just a casual glance, you'd see it. We had one time that actually Rabbi Azeri brought someone with a piece of sukkah in his eye after taking down the sukkah at the end of the holiday.
Wow. So really got to be careful with these things.
Very painful. Very, very painful.
So that you can pick up in a routine exam. That's with kids and, like you said, in adults.
Yes.
What else are you picking up in your routine exams?
So in our adult population, there's a myriad of things that are problems. Unfortunately, many people will come in not knowing they're diabetic, and through the examination, you'll pick up certain signs and symptoms of diabetes. One, that they increased urination, their vision is blurred from time to time during the day, and they're very, very thirsty. So those pick up some signs.
What, they're telling you that they're thirsty, or you're asking?
Sometimes you pick up one of the signs. They'll say that they're very, very blurry. And you'll ask, well, how long has it been going on? They'll say it's only a few minutes. And then they'll say, no, really, I have it every day at 4 o'clock. So you start to delve a little bit further, and you ask further questions, and you find that there's family history of diabetes, and you find that they're running to the bathroom very, very quickly, and that starts to put everything into perspective. And many of these patients are walking around with A1C levels, which is the glucose tolerance test, of over 6, 6.5, 7, and these people are at risk for full-blown diabetes. In the United States right now, there's almost 79 million people that are pre-diabetic, and there's about 20, 21 million people that actually are diabetic. So it's really become an epidemic in the United States today.
Wow.
Even among children under the age of 20, they found almost a 3 or 4% diabetic rate as well.
Wow. So when you're finding this, your next thing is then you're referring them for a workup?
Yeah, typically, we'll send them back to their internist, and if the internist feels that it needs further consultation, we'll go to an endocrinologist. But invariably, once their sugar is brought into control, their eyes return back to normal, thank God. They do have also the possibility of getting cataract after diabetic, something to think about very carefully. So we try to counsel people that are diabetic to have their eyes checked at least twice a year.
If you just joined us, we're here with Dr. Ezra Cohen. He's an eye doctor in the community for 32 years, and he's sharing with us some insights. We just discussed some of the things that he comes upon in a routine examination, bugs in the eyes, pieces of metal, and now adult diabetes as a important early diagnostic, hopefully early diagnostics. So what else are you finding now in your examinations?
So we've had, unfortunately, several situations where people have had tumors in their eyes, and they've had to have treatment in a number of ways, and they were not aware of these tumors. Some had to actually have brain surgery, and unfortunately, fortunately, thank God, the person survived, but it was a very traumatic situation. It took almost 6 months to recover. These patients, again, have no symptoms most of the time. They're coming for routine visits, and sometimes they're very startling to see the results of the examination.
Wow. So now, you're doing your routine exam. What is so different about the examination that you're doing and maybe the screening exam that they get when they're in school?
So in school, it's unfortunately, because of the training and the time element involved, it's very, very cursory. And many of the patients, many of the kids that are going through examinations are not picked up for many of their conditions. It's just really what's called a visual acuity, and it picks maybe a third of the kids that really have problems.
So they're missing. In other words, what they're looking at is an eye chart, and they're seeing what letters you see here, what numbers you see here. Basically, that's right. What they're doing.
And the testing conditions typically are very poor. It's in a hallway. There's a lot of kids surrounding them. They're making noise. Their friends tell them the numbers on the charts,
right.
And before you know it, they're passing the test, and they really need to be evaluated a little bit more thoroughly. Especially the people that are farsighted, that they can see well at far, but they can't see close. Those are called hyperopic patients, and a lot of the children are hyperopic and ultimately become cross-eyed because of the fact they weren't corrected.
Wow. So here we have your annual exam. What should a person then expect in their annual eye exam?
So through the initial examination, the doctor should give a thorough case history about their personal health, their family health, and any related conditions that they would want to discuss. Many times patients come in, don't discuss those, and those are very, very important factors in making a decision and a diagnosis for the patient. Of course, the patient's vision should be checked via the chart, but beyond that, they should have a comprehensive examination, which includes checking for the muscles of their eyes, making sure the eyes line up properly, making sure the tear layer of the eye is comfortable, meaning that many patients have dry eye and don't even know it, and they complain about their vision being poor, but in actuality, their eye is very, very dry. We're finding almost an epidemic in that, especially in postmenopausal women, where their eyes become dry, the tear layer is not sufficient for clarity of vision. It's very similar to having a windshield of a car where you don't have a washer fluid inside, and you keep on swishing back and forth, and you have no juice to make it work well. Same problem we have in terms of the eye as well. The tear layer is critical for clarity in vision.
So somebody who has dry eyes, I mean, what do? You're giving them eye drops that they use all the time?
So there's about 5 different things we can do. Number one, the primary thing, obviously, is basic eye drops to lubricate the eye. But we're trying to impress upon most of our patients to start taking omega-3 fatty acids, which are antioxidants and seems to restore the tear layer back to normal.
Wow, interesting. So in other words, if they're having these omega-3, what are they taking? In pill form?
Yeah, 500 milligram, 2 pills, 1,000 milligrams a day.
And that is helping them with this dry eye situation?
Yes.
Wow, interesting.
So that's first step. If that's not successful, then there is a medication called Restasis, which is also a medicine to reduce inflammation. Again, antioxidants or inflammation are all related together. And that medicine is taken twice a day. It's prescription medicine, twice a day, morning and night. And that within 3 months, it restores the tear layer as well. If a patient is beyond doing both of those and having still difficulty, then we can consider what's called punctal plugs. Plugs are little silicone plugs that we place inside the eye to stop the drainage of the tears leaving the eye. And with that, it's like a cork, effectively, and that's the most advanced level of care for the person with dry eye. So we start again with standard artificial tears. Omega-3s are good for everyone in every case. We go to Restasis as our third option, and fourthly, we go to punctal plugs.
Wow. So interesting. So somebody who has dry eyes in general, they always rubbing their eyes. What would you suggest off the bat is start with the omega-3 or start with the eye drops?
Well, the omega-3 they can do on their own regardless. The eye drops, again, there's about a myriad of eye drops. There's almost about 50 different brands, and each one has a specific function. Some are more related to the oil layer of the eye. Some are more related to the tears, the aqueous layer or secrets, and that has to be evaluated by the eye doctor. He'll tell you which one is best. The Visine and the Visine ACs over the counter have really a minimal effect. So you really have to decide which drop is appropriate for the patient. It's not just one drop that fits all.
Got it. Okay, interesting. So now that we're talking about you're going for your eye checkup and you're getting your thing, why we heard some things that you're picking up here, and seems to be why it's so important to have a regular eye examination. Now, I know myself, I wear glasses, and there's all different things that I'm finding that are out in the market that they're talking about on new advances in glasses and contact lenses. I mean, could you talk to us a little bit about some of the advances in, first of all, regular glasses?
Okay, so in glasses, as you know, for many years, patients wore standard lenses, which is called CR39, which is a plastic lens. And what's happened over the last, I would say, 10 or 15 years, they've found ways to thin out the lenses in glasses. And they're called indexes, and they go up to almost 1.74. 1.74 is probably the highest index and probably the most expensive of the lenses. And that'll give you the thinnest lens around. Now, when you go to these thin lenses, you always have to worry about safety. So there's always a balance between that. And the FDA, thank God, has made a decision to keep the standards at a certain level. If you go to Europe, interesting enough, you can probably buy thinner glasses than America, but they're not up to the standards of American safety.
Which means that what? They could crack in your eye? I mean, what could happen?
Yes, there's a test called a drop wall test that we do in America that is used specifically to make our standards uniform throughout the United States. In Europe, they don't hold from that. And you'll see that. You'll go to buy some drugs. You can buy amoxicillin in a pharmacy over the counter in Mexico, But while here we have very strict standards about things. So the same thing applies also to eyewear, that we have standards, and they call the ANSI standards, that we all adhere to.
So one thing that you're talking about is the thinness of the lens. What else is changing now that improvement or advances in eyeglasses?
Right. So for patients over 40 now, you see that people are wearing what's called bifocals. Now, bifocals, again, is a term for two focuses in a pair of glasses. And again, with advances in technology and machinery, they've come to the point of using what's called progressive lenses. Progressive lenses mean multiple focus, meaning that if a person wanted to look, say, from something as far away as 20 feet away, all the way down to, say, 16 inches away, they have one focus, and the lens will actually gradually change power as you go from top to bottom. And those are progressive. They've been around a while. Again, in Europe was ahead of us, and we've been hearing to that I would say, the last 15 years. The progressives have also advanced now just recently to what's called HD, or high definition progressives, which means another level of progressive. Typically in progressive lenses, you have on the periphery of the lenses, you get a little bit of distortion, which is inherently in the product itself. With the HD product, you get edge-to-edge clarity. They're pricey, they're very expensive, but they seem to be what's the standard going to be going forward. And you will see during the next 10 or 15 years, that'll be the standard product for patients to be wearing HD progressives.
Wow. So somebody who's over 40, they need to have glasses for reading, they need to have glasses for far vision. So you're saying that the progressive is the standard right now, and this HD, which is high definition, is going to make it much clearer. They'll have less distortion. That's going to be the way it's going to go. If they could afford it, they can do it right now.
Yes, and the technology, as products come out, the actual machinery, we say, was $1 million to produce the lenses. The actual machinery has come down to almost half. And as technology improves and they miniaturize everything, you'll see the price come down to a more reasonable level, more affordable for most patients.
Right. So I know also another thing that when it comes to glasses that people are always concerned about is the reflective or non-reflective nature of the glasses. They don't want to be, you know, standing in front of somebody and they see like a glare going back at them.
Yes, yes. So the anti-glare coating, we call it an AR coating in our lingo in the optometric field, has many advantages. Number one, obviously, as Dr. Doueck has said, it cosmetically, when you look at the person, you don't see the glare. You see their eyes through and through the lens. The other advantage is actually for the patient who's actually looking through them. They actually see better the other way also. So they're both getting advantage. The viewer and the viewee are both getting advantages in terms of these lenses. The technology, again, is kind of advanced. 15 or 20 years ago, people used to complain about the coating because they used to smudge and show dust marks on it. And with the advances recently, they have what's called hydrophobic, meaning water repellent, and oleophobic, dust repellent. So those factors have been incorporated into the lenses today and have made the anti-reflective coating, again, hopefully it'll be a standard. In Europe, it's about 95% of people get anti-reflective coating. In Japan, 99% get anti-reflective coating. In America, it's about 25%.
Wow.
So we're very far behind in terms of doing, what's hot, but eventually we do catch up.
So somebody wants to get a top-end pair of glasses. They're going to get it ultra thin. They're going to get this AR coating, which means no glare. They're going to make, if they need progressives, they're going to have HD.
Right.
This is going to be like a lot of bells and whistles on these glasses.
Not bad for the business.
And water and dust repellent also.
Yes.
So they got all these features of the glasses, which actually helps them see better, and they're, like you said, they're more cosmetic.
Yeah, a lot of benefit to the patient.
Great. So now that's the glasses end of things. What about the contact lens end of things?
So again, that's been advancing in the last, I would say, 7 8 years. A very, very big change. Most of the contact lenses, soft lenses per se, are being made out of what's called silicone. Now, silicone, as you know, has a lot of excellent properties in industry, but in the eye, it helps the eye breathe much better. You get much, much more breathability, and therefore, when the eye breathes better, you get more oxygen to the cornea, which is the front of the eye, and the eye's healthier. So it's about 62% of the market now is silicone, and the other products in the past have been phased out. Every company that has Johnson & Johnson, Ciba, they have all been moving toward that product for all their product lines.
So wait, are they still making what they call hard contact lenses?
The hard contact lenses is unfortunately, about 3% of the market. It has a lot of value, but people really don't want to go through the turmoil of the adapting period. It takes a bit of time.
Wait, so you're saying it has a lot of value. What is the big advantage of a hard contact lens? I mean, I remember something about shaping the eye.
Yes. So it's not been proven in the literature, but in actual practice, we found that patients that have hard lenses or gas-permeable semi-soft lenses actually retain a lot of their vision. Their myopia, their nearsightedness, doesn't progress at the same rate as a standard person with soft lenses and or glasses. And it's really remarkable when you see it. If you have a parent that wore contact lenses in the 50s and 60s and came back 20 years later and saw that their eyes didn't change, they were sold on bringing their child in for that same concept. They've gone one step further on the gas permeable. They came out with what's called a hybrid lens, which is actually a combination of soft and hard. The hard is in the center, and the soft is around the edge, like a skirt. So therefore, you get the comfort of a soft lens with the clarity of a hard. And for all our very, very technical and hard-to-fit patients, we've been recommending these hybrid lenses, and they flip. They really love it. It takes a lot of time to fit. I generally have a patient come at the end of the day, like a 7 o'clock patient, and we spend about 2 hours evaluating, and we clear the office because it takes a lot of time, and the standard fitting techniques do not apply for these lenses. So they're very, very, very exciting, and we're very gratified when we have a patient who cannot be fit in the past with other products. We're not getting the clarity through their soft lenses and did not have the comfort of their hard lenses to have the best of both worlds.
Wow. If you just joined us, again, this is Health Watch Radio. I'm your guest every week, Dr. Jacques Doueck. Our guest tonight is Dr. Ezra Cohen. He's an optometrist and eye doctor in the community for 32 years, and he's sharing with us some of his experiences and insights in the eyes and the eyeglasses, contact lenses, and all the ancillary things that go with it. So I'm just interested again about this gas-permeable hybrid. So you're saying people that had problems wearing what? They had problems wearing soft lenses?
They had problems. They couldn't tolerate hard because of the comfort issue.
Right.
But they need the clarity of the hard lenses.
So in other words, if you have soft lenses, I never wore lenses. So, I mean, I wore lenses for 1 week. It was the middle of the winter. The heat was on in my car. No, the heat was on in my car. They popped out of my eyes. I said, "That's it. I'm out." So, I'm not your classic contact lens patient.
The soft lenses fit a majority of the patients. There's standard soft lenses and there's called astigmatic soft lenses. So the astigmatic have a certain parameter range of what they can fit on, but if you have a cornea, the front of the eye, in front of the brown of the eye, which is called the cornea, that is irregular, the soft lens won't do the trick, and you need something to compensate for that. So that's where the hard comes in.
But you're saying that really only 3% of people are using the hard. So what happens is if they have this irregular cornea, they have to really use glasses, or now you have some other option of the hybrid?
Well, the glasses, unfortunately, for those people with irregular corneas, don't work either, because the glasses are very similar to the soft lens in that it just doesn't cut it. It doesn't give them the clarity they need. They need almost like a girdle on their eye to try to make everything uniform, and that's where the hard lenses is the key. Unfortunately, there's not many practitioners that still do hard lenses. It's a lost art. And you really have to be a special person to be able to take the time to do it. A doctor would rather do the soft lens and let the patient go rather than spending their time doing the hard lens. But they're very rewarding in terms of the response.
So again, you're saying that the hybrid soft-hard, the big advantage is for this patient that has this irregular cornea, or who else is that good for?
It's good for people that, some people that have, as it's called irregular corneas, they have what's a condition called keratoconus. Keratoconus, again, is about 1 or 2% of the population in the United States. Is when the cornea of the eye becomes so steep, like a mountain, and it almost, God forbid, may perforate because of the steepness of it. So you put these lenses on top of those corneas, and you arrest the process. You can't return it back to normal, but you can arrest the process. Speaking about keratoconus, we should mention something that came out, again, and FDA has not approved it, but it's been done in a research setting in about 15 centers around the country. It's called riboflavin. Riboflavin is a vitamin A. And what they've done for these keratoconic patients, where their corneas have been so irregular, they paint the eye literally with this riboflavin, and they sit under ultraviolet light for 30 minutes. And they found that the riboflavin causes the cornea to stiffen up and to become back to its normal shape.
Wow.
Really, really fantastic. It's non-invasive. You lay down on a couch, and the doctor paints the eye with the chemical, and you sit with the ultraviolet light for 30 minutes, and it takes about 6 or 7 weeks to get back to shape. And those corneas are much easier at that point to fit with standard soft lenses at that point, once they have their cornea back to shape. It doesn't reduce their power down to zero, but it gives the doctor a much better working surface to work with his eye.
Interesting. So we're talking about eyeglasses, we're talking about contact lenses. Let's talk about laser vision correction.
The holy grail of eye care. Laser vision correction is around since about 1998, and it's gone through 3 or 4 changes in that period of time. It started out with a technique called PRK, which was unfortunately very uncomfortable, and it took a patient almost a week to heal. Then they went from PRK to what's called LASIK. LASIK is a technique where you actually peel off several layers of the skin of the eye, which doesn't hurt at all, and laser the eye in the hope of reducing their prescription and putting back those natural layers back onto the eye. So that was stage number 2. So you went from PRK to LASIK. The newest one is called femto laser. Femto laser actually makes a laser to make the peeling. Before they used to use a blade actually to make the peeling, and now they use a laser. So we call it laser on laser. A laser to make the peel, and laser to check the prescription and to get rid of the refractive error. So that's the latest one, the fastest healing, of course, the most expensive of the 3.
So now, vision correction, this is great. But, I know that a lot of people have issues with their eyes that they need surgical treatment. For example, cataracts or other things like that. Could you comment a little bit about cataracts, about macular degeneration?
Okay. So cataract surgery has evolved from 30 years ago where really you had to stay in the hospital overnight, literally. They kept you for a day and a half. Now the actual cataract surgery is about 7 minutes long.
Wow.
And it's gone from having 7 or 8 sutures in the eye to going sutureless. The incision that they make in the eye is so small now that after they place what's called the intraocular lens, they take out the natural lens of your eye. In a cataract, you actually have the natural lens of your eye, like an onion, which actually turns yellow. And that yellowing causes you to see poorly. So what they typically do now is they put a little incision to the eye, bloodless and bladeless, go into the eye, they vibrate the cataract, they ultrasound the eye, and they actually suck it out with a vacuum cleaner.
Wow.
And from that small incision, they pull out their instruments, and it's called self-sealing cataract surgery, where there's no suture involved. So the eye, literally, after surgery, looks like it was never touched. Really, really fantastic.
So my son was asking me, he says, are you going to you're talking to the doctor? He goes, you're going to talk about that disease. What's that disease? Like, it sounds like guacamole.
Guacamole.
So
I wish it would taste as good as that.
He says, so I says, you mean glaucoma? So could we talk a little bit about glaucoma and how that, who gets it, why they get it, and what we have to know about it?
So glaucoma is probably our biggest problem in the eye care field right now because it's silent. In 95, 98% of the patients, there is no pain. And the vision loss typically in glaucoma is in the periphery. So people don't even know that they have it, and God forbid, until the last stages of glaucoma where their central vision is lost. Glaucoma is basically a pressure issue. Either there's too much fluid being produced by the eye or not enough fluid is leaving the eye. Typically, there's not enough fluid leaving the eye, and that requires either drops and or surgery to correct that. But it's a silent problem for the eye, and probably our biggest challenge right now.
So when somebody comes in for a checkup and you're saying that the peripheral vision may be compromised,
yes,
you're picking that up because how are you seeing that?
So there are 4 things that we do in an examination when we're looking at what's called a glaucoma evaluation. First, obviously, we ask for family history. If there's any family, if a mother or father has glaucoma, that sends a red signal right up front. Secondly, we take what's called a glaucoma test. It's a blue probe that we check the pressure in the eye to see if the pressure is within normal. Normal pressures are under 20 is the average pressure in the person. Then what we do is we look inside the eye at what's called the optic nerve. In a person that has glaucoma, the optic nerve is compromised. From the pressure, from the glaucoma, the nerve becomes pale instead of pink. When you see that what's called pallor in the eye, we have another sign of a potential glaucoma patient. We continue the examination with what's called a visual field. A visual field is a peripheral vision test. Again, as we spoke before, typically in glaucoma, the peripheral vision is affected first, and then the central vision last, unfortunately. So if we pick up on a peripheral visual field test compromised in the peripheral vision, we know we have one of the signs of glaucoma, and we're much more aggressively going to treat that patient.
So as we're listening now, my listeners are hearing many reasons why it's important to get regular eye exams. I mean, just this idea of the glaucoma alone I'm assuming this is really more of an adult problem than a problem in children. Is that right?
We only have maybe a handful of children with glaucoma. Most of them were born, unfortunately, with it. It's called infantile glaucoma, and unfortunately, they're blind from birth.
Wow. But, this is more another reason why it's so important to get the regular eye examinations. People have things that they don't know that they have and that are easier to treat when they're caught early. So glaucoma is one of them.
Very much so.
Right. Another thing that we talked about was the adult diabetics, picking that up. And one of the ways is they may be complaining of blurred vision and not think it's such a serious thing and not think it maybe that it's something significant at all. But in the examination and in the history taking, those are the things that you're looking for. and trying to catch early so that you can treat early. And of course, like you said, tumors in the eyes, dry eyes, and other conditions that may be caught early so that we can treat them early. Is that right?
The hypertensive is also an issue. We've had many patients that actually had strokes in their eyes that didn't know it also. Again, you look with both eyes. Typically, a person will not cover one eye versus the other when they're walking in the street. And we've had many patients walk in, and you'll literally see a splash of blood in the back of the eye because their blood pressure had gone out of control. Many of these patients are obviously may be diabetic as well. They may have cholesterol problems. We've had patients, we actually saw what's called plaque. You heard about plaque in the arteries of the heart, where they have strokes and thrombi. We actually have that in the eye as well. We've actually had patients where you look inside the eye and you see a plaque or a cholesterol plaque in one of the eyes causing a stroke.
Wow. So again, more reasons why it's so important to get your routine eye examinations and not think, oh, what's the big deal? I don't have any problem, because these are the things that get picked up in the routine eye exam. Can we talk a little bit about macular degeneration?
Macular degeneration has become, as diabetics became an epidemic in the world.
What is macular degeneration?
Macular degeneration, there's a very special part of the eye called the macula in the back of the eye. That's the central portion of the vision. It's the size of a pinhead, actually. And that, believe it or not, God gave us the ability to see from that little pinhead. The eye is fairly large, but this area is very, very minute and very, very special in its function. Macular degeneration actually is a deterioration of that area of the eye, of that pinhead area. There are two types of macular degeneration. One is called wet, and we'll explain that in a moment, and one is called dry. The wet means there's actually bleeding inside the eye. The blood vessels of the eye inside are very fragile, and they've broken off and actually act bleeding, and those blood, when it resorbs, becomes scar tissue. The second type is called dry, meaning that there is no blood inside the eye, but you see actually scarring. The people that seem to have developed this, again, are diabetics, people that are overweight, people that have smoked over the course of their lives. And some people just, Hashem decided. And each one has a different course of action. The wet one is very interesting. Many years ago, all they could do for the wet was take a laser and try to literally seal the blood vessels that were broken. And the problem with that is that it stopped the blood, but wherever you hit with the laser, that area of the eye was damaged permanently. So you gained something, but you lost something. In the last 12 to 15 years now, they've come out with injections now to inject inside the eye monthly on a 3-month basis, and then they have a series of injections post to that, which actually hones in on that particular blood vessel that's leaking and seals it. And there's 3 drugs that are being used right now. One is called Avastin, one is called Lucentis, and the most recent one that just came out about 6 weeks ago is called Eylea. Eylea seems to be the biggest promise going forward because the amount of injections and the period between injections has been reduced markedly. So it means the time that we normally would have an injection in a month, we'd have it maybe in 2 months. So there won't be as many injections going forward. So that's the most recent advance. But this drug seems to have a lot of advantages for a lot of patients where they'd have to have invasive laser surgery to seal the blood vessels. They don't need it anymore. It's a much more cleaner approach.
You know, I wanted to talk a little bit about something that myself, I remember the first time it happened to me, I got very concerned, and that is vitreous floaters. I wanted to talk about that. And connected to that, I wanted to talk about detached retinas.
Okay.
So let's start with vitreous floaters. I'll share my personal experience, and you tell me what you see in the real world. My personal experience was one day, all of a sudden, I see something floating around, black thing floating around my eye, and I said, whoa, what is this thing? Something very scary. And then I speak to a bunch of people, and they're all telling me, yeah, I have that too, and I see that too. So then I felt a lot better that it wasn't anything. Go ahead.
Let's talk a little bit about the vitreous. The eyeball itself is round, but inside the eye is hollow. Now, something has to hold that eye in shape. And what holds it in shape is called the vitreous. The vitreous is actually jello. It's a jello. It's a clear jello. Okay? It's a clear jello inside the eye that keeps everything intact. and it's a space where nutrients flow back and forth between the front of the eye and the back of the eye. As we age, the jello goes from solid to liquid. It changes its format. And when it changes from solid to liquid, it starts, and you start to see these little spider webs and cobwebs and bugs floating in front of your eye, free as a bird, all day long, up and down, side to side. Now, most of the time, the vitreous, these floaters are not a problem for us, but there are a certain number that are very, very dangerous. In that, if you see, say, flashing lights or zigzag lines or a shooting light from the side, that could be a sign of what's called a vitreous detachment. In itself is not a problem, but which can lead to what's called a retinal detachment. Now, the vitreous is attached to the retina. The retina is the skin of the inside of the eye that does all your seeing. If the vitreous pulls on the retina, you can have what's called, as Dr. Doueck said, a retinal detachment or a tear, and that's an ocular emergency. Now, in the office, a person coming with flashing and floating, obviously, we know what to look for. We've had literally tens of patients come in with no symptoms, which is really, really frightening, and end up to be having surgery the following day with no symptoms because, again, the tear was small or the detachment was small and they weren't aware of it. Typically, these retinal tears or holes or detachments are in the periphery of the eye, again, not sensitive to the patient, and therefore have to be evaluated on a regular basis. People that are very nearsighted, when you say, if you know your glasses are -5, -6, -7, -8, those people are more prone to detachments or tears or holes in the retina because the eye is stretched and they can break at any particular time. I'm not having everybody running to the eye doctor tomorrow because they saw a floater, but just to be aware, if you do see floaters on a chronic basis and they are increasing, you definitely should have it evaluated.
So, very important point here that we're talking about, and that is that vitreous floaters, these little things that are floating around in your eye, they could be nothing. They could be just routine things. But the big concern that we have and the big risk that everybody should be worried about is a detached retina. And one of the signs, but not necessarily it may not even happen, and that is the flashing lights. Somebody has flashing lights, that's get right in and get it checked out. But besides the flashing lights, by going for your routine eye checkups, these are the things that are going to get picked up. These are the things that are going to be able to be treated when they're small and easy to handle. Again, this is Health Watch Radio. I'm your host every week at 8 o'clock, Monday nights, Dr. Jacques Doueck. Tonight, our guest was Dr. Ezra Cohen. He's had 32 years of experience and shared a lot of his insights with us. Could you give us a summary statement so that our people can go away with some good feeling about what to do with their eyes? And I think they understand pretty clearly from all the things that we've discussed how important it is to make sure that they're getting in for regular eye examinations, all the different things that have to be picked up that could be a concern: adult diabetics, glaucoma, tumors in the eyes, dry eyes, macular degeneration, cataracts. There's so many things that could be a problem and could be easily diagnosed by a regular routine checkup.
Really, in summary, we should say that, almost 85-90% of our learning comes through our eyes. We do through touch and feel, we do through hearing, but our eyes have a very, very important role in our daily lives, in our businesses, in our home. Even, when you're sitting with a person, you're doing business with a person, you look at his eyes, and you look to see, the truth in his eyes, and you could say from his twinkle in his eye what he's all about. And on a average basis, I think it tells a lot about a person, what they look at. Yafeh Einayim, right? David HaMelech, right?
If you can't look somebody in the eye, you got to worry if they can't look you in the eye. Thank you very much, Dr. Ezra Cohen, for joining us. If you want any information, he has a website, sensationeyewear.com, or you could call him at the office at 718-946-5060. It's sensationeyewear.com, or at his office, 718-946-5060. He's right here on Avenue U. He's been treating this community for 32 years. Dr. Ezra Cohen, thank you again for joining us.
Thanks for inviting me. For inviting me.